Welcome to Unit 3 of the Epidemiology of Healthcare-Associated Infections and Long-Term Care. Hopefully you had a chance to watch Unit 1 and Unit 2 in this series, and I'm going to talk about some basic precautions that can be taken to reduce the risk of disease transmission, because in the past some of the things we've done just didn't work very well. For example, in many times we only implemented precautions when we knew somebody had a disease. We didn't pay attention to those people I talked about earlier who are colonized or simply carrying an infection. And this particular graphic puts that into great perspective. This is called the Iceberg Phenomenon in epidemiology. Again, it's not rocket science, but if the known case of an infection is what you see, that's what you know about. And if you think about it, let's take a disease such as AIDS as an example. People with full-blown AIDS have night sweats and fever, weight loss, they've had a test done and they've been shown to be positive. We can say, aha, this person has this disease. But if we're putting precautions together to protect ourselves from a disease such as hepatitis or HIV or hepatitis C, in any case, you want it to work all the time, not just when you know about it. 65% of people with HIV have no idea they have it yet. And I'll give you a couple other examples. This one's probably better. Hepatitis B. 1 out of every 100 patients admitted to a healthcare facility in the United States has hepatitis B that will never be diagnosed while they're there. So if you only pay attention to people's blood who you know have hepatitis B, you're missing the boat. The same holds true with things like hepatitis C. I'll give you another example with Staph aureus. Patient comes into the hospital, or into the long-term care facility, they have a draining decubitus ulcer. Someone says, get a culture of that, we culture it. Culture comes back 3 or 4 days later and it says, oh, they have methicillin-resistant staph. The next thing you do is say, oh, put them in isolation. Well, the drainage has been there for 4 days. So if you haven't paid attention to that drainage as though it was infectious from the beginning, you're missing the boat. And I could belabor this, but I think the best examples come down to the bloodborne pathogens that I've already mentioned, the vehicle-transmitted diseases. And I'm bringing these up because they presented a particular problem in long-term care the last few years. Specifically, hepatitis B and C I'm going to focus on because they're more likely to occur than any of the rest because they're, one, more common, and two, they're more prevalent in terms of the amount of virus that's present that can infect people. There's more virus circulating in the blood. For example, it takes less than the amount of blood that you put on the tip of a pin from someone who has hepatitis B to cause disease. Whereas it takes far more to transmit something like hepatitis C or HIV. So there's a relative risk there, and I always call it the rules of 3. For example, if you should get stuck with a needle from someone who's got hepatitis B and they're E antigen positive, the odds are around 30% that you're going to get infected if you haven't been vaccinated. With hepatitis C, it's like 3% risk. And with something like the HIV, it's 0.3%. So for the most part, you can see the relative risk is related to the amount of virus present. And that's why we see hepatitis B and C transmitted more often in the healthcare community. In fact, CDC just published a paper a couple of years ago where they looked at 40 healthcare-associated outbreaks associated with that were investigated by the Center for Disease Control. It involved more than 500 infected patients in a variety of settings. There were 11 outbreaks caused by hepatitis B and C in 10 states, and there were over 120 people infected. 9 of the outbreaks occurred, 9 out of the 11 occurred in non-hospital settings, and all of them had basic infection control breaches. Now, some of them occurred in outpatient clinics, but also they occurred in skilled nursing facilities and nursing homes as well. And if you all remember, just a few years ago, the OSHA came out and said you need to treat all blood and bloody body fluids as though they're infectious, and they called that universal precautions. They said treat all blood, bloody body fluids, and opium, other potentially infectious materials, as though they are infectious. And then they defined opium as saliva in dentistry because it might contain visible blood, internal fluids such as joint fluids, amniotic fluid, but it doesn't include urine, saliva, feces, any other body fluid unless they contain visible blood. Well, you can get other diseases from those body fluids. So universal precautions, that term has now been replaced. It no longer exists. The term has been replaced by what we call standard precautions. And some facilities used to call this body substance precautions, but now they're calling it standard precautions. And what it is, in terms of a prevention strategy, it says it's the minimum infection prevention practices that applies to all patient care regardless of the infectious status of the patient. Going back to that iceberg I showed you, what they're trying to do is get you to become consistent and practice the same way for all of your patients. This system is designed to protect both the patient and the healthcare worker and includes things like hand hygiene, the proper use of personal protective equipment, safe injection practices, safe handling of equipment in the environment, and then finally what we call respiratory hygiene or cough etiquette, where you're taught to stay home if you're sick, and if you're coughing or sneezing, that you cover your cough. Again, common sense, but things that we should be doing all the time. And I'm going to show you the reasons that this standard precautions works better. And I think, again, that iceberg that I showed you before gives you the best example. But most systems that we've used in the past has targeted that known case of infection. And what it ignored was that the mouth, nose, vagina, rectum are always colonized with bacteria, viruses, or fungi that can cause disease if they're somewhere else other than where they normally live. Skin lesions are also normally colonized. Body fluids such as feces, airway drainage, wound drainage always contain bacteria that if you put them somewhere else, they may cause disease. Blood, urine, and internal fluids are almost always sterile. So very seldom are they considered a problem. However, we never know when they are and when they're not. So what we try to do is teach people to follow the same precautions at all times for all moist body fluids. Okay, in the past, one of the problems with our isolation system, they've been what I call diagnosis driven. And what would happen is the doctor would come in, put the patient's diagnosis on the chart. The nurse would then put a sign on the door, say, take this precaution, and then people would put on gowns, masks, gloves, or whatever in order to take care of that patient. Unfortunately, if the doctor didn't write anything in the chart or didn't know what the patient had, people would not take any precautions at all, and that's where we ran into a lot of transmission of these infections. So when we get to standard precautions, basically what they're saying is anytime you're going to have contact with moist body substances or something that's soiled by them, that you're going to implement standard precautions, so meaning for anyone. You're going to use gloves, protective face and eyewear, aprons and gowns. Obviously, we emphasize hand washing and then being careful with handling sharps and disposal of those devices. We teach people to wear gloves anytime that they're going to have contact with mucous membranes, non-intact skin, or moist body substances for anyone. It's really important when you're handling gloves that you understand that dirty gloves are worse than dirty hands because things adhere to them. So they need to be changed appropriately after you performed a particular procedure. You need to change them and wash your hands. The other thing that we advocate, if you're going to soil your clothes, not the patient that you know has a disease, anytime you're going to soil your clothes with somebody's body fluid, it makes sense to put on something to protect your clothing. And then finally, it doesn't happen a lot in nursing homes and skilled nursing facilities, but if you're doing a procedure where splashing is likely, where like in an ICU, often when someone is suctioning a patient that's on a ventilator, and ventilators are now commonly seen in skilled nursing facilities, that you may take that precaution of protecting your eyes and face during that process. And the idea is the mucous membranes are protected that way. Then finally, of course, we talk about hand washing all the time, and it's the paradigm of how to wash your hands in healthcare has changed in the last couple of years. The Center for Disease Control now advocates that people use alcohol-based hand rubs as the primary mode of hand washing in a healthcare facility. Now the reasons for this is because of their broad spectrum activity. The alcohol works very well in killing things that are on your hands. There's increased compliance with doing this because, one, you can make it more convenient. You can put it by the door coming into the room. what have you, and it takes less time to use it. They dry fairly rapidly, and there's less irritation, and because of that availability close to the patient, people are more likely to use it. Now, that's the new paradigm that the CDC is promoting. However, they put two caveats associated with that. Whenever your hands are not visibly soiled, or when caring for patients with diarrhea. Those are two exceptions. Anytime your hands are visibly soiled or you're caring for somebody with diarrhea, you should go to the sink and make sure you wash your hands with plain old soap and water. The reason for that is antiseptics, disinfectants do not work in the presence of organic matter. So if someone has contaminated hands that have been grossly soiled, alcohol-based hand washing agents are not the thing to use. Go to the sink and for 15 to 30 seconds with some warm water, wash your hands that way. When should you do that? I'm not going to list here. I could put a long list of when you should wash your hands and when you shouldn't, but obviously the things that are on this slide are very important. That last one, anytime you remove gloves, you need to wash your hands before touching a patient, even when you're wearing gloves. So if you can read this slide for yourself and see exactly when and where you should wash your hands. What I wanted to jump to was one of the latest problems that we've seen is in the area of injection safety. And the Center for Disease Control has what we call a one and only campaign. It's a public health campaign, and it's designed to raise the awareness among patients and healthcare providers about safe injection practices. And the campaign, the URL for the campaign is here on this slide, and it's something that you should go to. You should take the time and go look at that video. And I think if you push right here on your screen, you can travel right to that particular video. What I'll do right now is just mention some of the things that are in there, though. This is very important. Obviously, you use aseptic technique when you prepare and administer medications. If you're opening a medication vial, you need to clean the access diaphragms with 70% alcohol before inserting anything into that vial. And never administer the same medication, or never administer medication from the same syringe to multiple patients, even if the needle's changed or the injections administered through the intravenous tubing. Now, the point here is a syringe is considered a single-use device, as is a needle. And the procedure you should follow, if it's anything says single patient use, it belongs to that patient. It should not be used on multiple patients. You do not use the same syringe to enter a medication vial or solution. Do not administer meds from a single-use or single-dose vials to more than one patient. Even recently, we've had outbreaks associated with a medication coming, say, 50 cc vial. Only 10 cc's were used, and most people would like to save that and use it on multiple patients. No, that's designated for that patient only. If you're only going to use 10 cc's, you have to throw the rest of it out. Do not use fluid infusion or administration sets for more than one patient. Again, the same premise. And then if you are using multi-use vials, and the difference between a single-dose vial and a multi-use vial is usually there's a preservative in the multi-dose vial. In that case, you should dedicate it to a single patient whenever possible. And if it's used for more than one patient, restrict its use to a central medication area. In other words, don't take it into the area where the patient is being treated. That way you're less likely to make a mistake and use it on multiple patients. One other thing, when it comes down to safe injection practices, something we've seen in the past few years, and again in long-term care and skilled nursing facilities, nursing homes, you're less likely to encounter this, but if you're doing any injection into a patient's back, if you're using any kind of contrast dye, say for radiologic examination or something like that, the person inserting that needle and the people in that room should be wearing a mask. We have had recent outbreaks of meningitis simply from normal oral flora in people's mouths infecting the patients, and the Center for Disease Control has found that simply by wearing a face mask during that procedure will eliminate that risk to the patient. Now, I just went over what I consider a lot of basic material about standard precautions. There's a lot of advantages to this. Common sense. There's nothing rocket science about anything I just told you. You don't need somebody to diagnose it for you. You don't have to wait for a doctor to tell you, hey, that patient has hepatitis. If you've been consistent in your practice and you do the same thing for all patients, you don't have to worry about that. It should become part of routine healthcare worker behavior as we teach this more and more, getting away from that diagnosis-driven type approach, that people do this for all their patients. And what that does to me, it gives me a scientific approach to this. It's consistent, it's defendable with scientific literature, and it gets rid of what I call the uh-oh factor. When I walk into the room and happen to tell you, oh, Mr. Jones has X disease, you don't go, uh-oh. Instead, what you do is say, I don't care, I followed the right precautions all along. Now, there are times when standard precautions are added to. In other words, when routes of transmission is not completely interrupted using standard precautions, the Center for Disease Control has added what they call transmission-based isolation. There are three types: contact, droplet, and airborne. And they're always used in addition to standard precautions. And one of the things that's very important in long-term care, especially in a nursing home or a skilled nursing facility, these are people's homes. This isn't like acute care in a hospital where people come in and then go home. People live in these places, so it's important that you make all the efforts you can to counteract any possible adverse event related to putting them in some type of isolation. You have to make decisions in patient placement based on a case-by-case basis, balancing the risk of other patients in the room, the presence of risk factors that increase the likelihood of transmission, and potential adverse psychological events. We know that patients get anxious and depressed and go through other mood disturbances when they're put in a private room by themselves. There's a perception of stigma, reduced contact time. We know that doctors and nurses don't go into a patient's room as often if they're on isolation than if they're not. So in case of acute care, they're very rigid about how they handle this kind of thing. In long-term care, you may have to make some adjustments to make this so that the patient has less harm done to them as a result of this. Okay. I mentioned the transmission-based precautions, and there are three types. The first one is contact isolation, and we use this for diseases that are known to be transmitted through contact. Examples include multi-drug-resistant organisms such as methicillin-resistant Staph aureus, vancomycin-resistant Enterococci, or carbapenem-resistant Enterobacteriaceae, and I'll talk about them a little bit later because they're the new guy on the block. Precautions include basic things like hand washing. One of the differences is you put these patients, when you can, in a private room, or you cohort them with another patient, or put a partition between the patients when that's not possible. And you put on gloves and a gown before you enter the room, and you remove those before you exit the room and wash your hands. That's called contact isolation. The second one is droplet isolation or droplet precautions, and this is used to prevent transmission of pathogens that are spread through close respiratory or mucous membrane contact with respiratory secretions. Diseases like whooping cough or pertussis, influenza, adenovirus, rhinovirus, all these viruses that cause common colds. And in this case, a patient, for example, the one that would be seen the most in nursing home or skilled nursing facility would likely be someone with influenza. In these cases, you try to put these patients in a private room. If you can't do that, again, you cohort them, separating them by at least 3 feet, because I mentioned before, droplets travel about 3 to 6 feet. Wear regular isolation masks if you're having close contact with that person. And then you put a mask on the patient if you're transporting them somewhere throughout the facility, if they can tolerate it, and follow the respiratory hygiene or cough etiquette otherwise. And then finally, the last type of transmission-based precaution, you won't see a whole lot in a nursing home or skilled nursing facility because these are airborne diseases and they require you to have special rooms with negative air pressure so that the air isn't blown out into the corridor. So most of these patients are transferred to an acute care facility or to another facility that has these types of facilities available. Now there are long-term care facilities in nursing homes that have negative air pressure rooms, and in those cases you're going to put the patient, you're going to use an N95 respirator that has been properly fit tested and full fit testing program has been put on there. For diseases like chickenpox or measles, in these cases, you want to make sure that anybody who's caring for these patients have been properly immunized. But you would need negative air pressure for these patients, and in most cases, someone would put something like a stop sign on the door that says, check with the nurse before entering, so they could make sure that people were properly immunized before entering those rooms. Thank you for watching Unit 3 of the Epidemiology of Healthcare-Associated Infections and Long-Term Care. We're going to move on to Unit 4 and talk about healthcare-associated infections that are commonly seen in nursing homes and skilled nursing facilities.